They call it content. Okay. Now, what is going to happen? Because I said I don't want to open. Okay. Now, we are going to discuss 3 issues. We are going to discuss 3 issues. And we are going to look at barriers to disclosure. Yes, the first one is barriers to disclosure. Adolescents. Well, let me read them properly here.
Barriers to disclosure and youth.
Yes, the first one is barrier to disclosure to children. 2 is barriers to disclosure to adolescents. And they say with neonatally acquired HIV. I don't know, that one, the doctors in your group.
So that one, those or when they were still in utero or during breastfeeding.
Yeah, Zali one. Yes, we get it. That child who was born with the HIV has grown, maybe taking medication all through. What are those barriers to disclosing to them their status? That is the real point they're talking about here. And then lastly, barriers to disclosure by adolescents. The other one was 2, but this time is by, as an adult. Maybe they can do and make it very hard to disclose to them or even themselves to disclose, maybe to their peer, to their boyfriend, to wherever. We get it? So that is how our discussion, those are our points of discussion in our respective groups.
Barriers to disclosure by adolescents.
By adolescents.
By BYE.
So it's themselves, like if you say stigma. Now, what is going to happen in the groups? When we sit in our groups, we are going to brainstorm. The methodology is brainstorming. And we are going to talk through those points listed. And we shall have a note taker in our group who will pick a marker and a flip chart and write our points as we brainstorm on each of the issues being raised, on each of the barriers to children, to adolescents, the ones we've explained from birth, and then by adolescents. Barriers to disclosure by adolescents. So we brainstorm on all those, and then the note taker within our group will write those bullets of the issues that we are raising onto the flip chart. Now, what will happen after we are done with that? We shall have again within our small groups a small group discussion. And then we'll have an opportunity to rank the points that we've put across on each of the questions, can I call them questions? Those barriers, those issues that we've discussed. And then we'll rank using stick notes. And we'll be picking out the best 3 that stand out. Out of all, maybe on each item you've listed 10 points. But the best 3 that you think stand out, we shall be able to rank them. And once we are done with that, we'll come here and have a fishbowl discussion like we did yesterday. We shall have a representative from each of the groups come and sit here, and you will give us feedback. As I was starting, I said, let me try to be natural. I'm trying to read less, because I saw that we like reading very much. Now when we come, let's just come and talk natural, what you remember that we discussed. But the focus can be on those 3 issues that we've ranked, and we discuss in that area, go deep, what are these barriers, giving examples. And when you come here, you're representing the whole group. You are not representing your facility alone. But what I saw yesterday, when we came, everyone would say, like at my facility. Now, in that group, you had someone from Mpongo, you had someone from Butunduzi, you had someone from Alive Medical Services. So, I want to hear those examples that in our group, like at this facility, this is being used and it's working. And then the other facility, that's the kind of story we want to hear, but not again just stick to your facility, because you're representing the group and with all the different facilities or workstations that were in there. So the discussion will go, we are not asking anything different, but to just talk about the issues that you were raised, and you tell us the story. And again, we'll record that session. We shall have it on camera, we shall have it on voice recorders, and then the rapporteur will also be documenting. And whatever you'll have put up on the charts, on the chart papers, we shall also photograph them, and we shall share the pictures with our team leads back in South Africa. Do we have questions before we break? Is the assignment clearly understood?
Let's come to this point. I think I can be audible. Sorry.
They are recording.
What I'm trying to ask is, in every group, are we answering all the 3 apart from your main, or we are answering your main question? There are 3 questions, right?
4, right?
There are 3.
Which one?
They are 3.
There are 3. At least I'm okay. So what I'm asking, are we answering all in a team, like in a group of like say 3?
Back, we are 3 groups. The nurses and the doctors together. We have the second group of counselors. And given the numbers in the house, I propose that even civil society guys join, maybe the counselors, if that is okay with us. But if we want a separate group for civil society, we can call it others. So, if we join that one, then the third group is peer supporters. Now, they are not even like questions, but there are 3 issues. We are discussing barriers in 3 categories. The first one, barriers to children. Barriers to disclosure to children. What makes it hard for you to disclose to children? That is the thing. Then, the second is barriers to disclosure to adolescents. But those ones who acquired either at birth or through breastfeeding, or the one the doctor calls neo what?
In utero.
That one. Disclosure to those ones. Because it's easier to disclose to me if maybe I went out willingly and slept with somebody and acquired it. But this category is also different. They think, but we didn't even do anything. So it's what makes it hard to disclose to that group. What are those barriers? So that is where I emphasize. And then the last one is disclosure. Barriers to disclosure by
adolescents. Them
by themselves.
To friends.
Yes. So they may do something that makes it hard for you to disclose to them, or them even disclosing maybe to their boyfriends, maybe to that is exactly what we are talking about. So 3 issues, or we can call them questions. And then we say, when we sit back in our groups, we may sit on round tables, and the methodology is brainstorming on each and every issue or question. We finish that one, we go to the next one. So as we brainstorm on barriers to disclosure to children, one of us is not summarizing our points into bullets on a chart. And then we get to another question, then again, they are summarized. Then to another, and they are summarized. And the counselors, the nurses, the doctors, and the peer supporters are discussing the same questions. Each group is discussing the same questions. Then when we are done, we shall rank them to get the best 3 that stand out. The best 3 that stand out on each question. Like what are those 3 issues that are common, that are standing out all over? So when we rank them, and then when we come here, we shall mostly speak into those. But of course the discussion will be open. If you feel something is left out, again like the methodology was, you just come, tap on the person you want to make an addition to, and then they will leave and you take the floor. And once we are done, it will be just picking the issues that you came up with, and our discussion will end. And that is how today is to run. Do we still have questions? Okay. The last question.
The third one. How is the third one defined? Barriers to disclosure by adolescents.
Barriers to disclosure by adolescents.
And the second one?
Barriers to disclosure to adolescents. That word I must read it to mention it.
Who were born perinatally.
You're confused that.
But they explain.
Perinatal we understand, but not all. Some people you're confusing them the more.
When they say perinatal, I think we are good to go. Aren't we?
Yes.
Okay, great. Now we need to balance up the room. I know maybe 60 or 70% might be nurses and doctors in here. Maybe let me see how many nurses and doctors are here. That group.
Nurses and doctors by training.
Some are by calling also. Yeah, the doctors like Marian.
By osmosis.
We can take the floor here, the counselors, the what, we can be around here. Then we can have another group in that corner and another group in the boardroom. Peer supporters. Let me see how many peer supporters are in the house.
There are about 3.
Yes.
3, 4. There are 5. They're supposed to be 5. They're not seated outside there.
Now, peer supporters, I think you trust
There
me,
are 5.
you trust Isaac, we can add Emmanuel, we are joining your group. Okay, in the interest of time, let's take our positions and then. Yes? Okay, the peers, let's go to the boardroom. The peers, let's go to the boardroom.
Peer supporter.
Yes.
Doesn't really see this, but he should examine it. He has that machine. But as you said, God would
we want to borrow from the health workers, those who do counseling, please join the counselors, a few of you. The counselors are coming to sit here on the high table here.
Actually,
but peer will have 4, right? You have one. The groups are what? 3. Which group should have one?
We are not mixing the
Nutrition.
5 minutes.
They say would be a supporter, so who will I can't even brisk grade. It's not
Emmanuel, Isaac, you need to be part of the counselor.
Isaac has disappeared.
All of them are saying
That's surprising.
what's your doctor?
No,
We're answering them in the past.
engineer.
Nurses.
Yes, this side here is for the
Nurses and counselors.
counselors. Obusungu bungi.
Let's first understand. Then adolescents, 11, 24. So there's a fish taking so some wonder barrier. Children first. You can yes. The so one of the barriers, the caretakers, some of the caretakers will not allow some of the caretakers that we face will not allow them to disclose to their children.
What is that reason? Why? Then
Okay.
it becomes the barrier, yes?
Okay, so the reason as to why they do one, the judgment.
Fear judgment.
Fear to judgment.
Some caretakers fear judgment.
From their children, judgment from because if I tell the child, if she tells my child that the child my son is going to be taken, then the child will start.
I think this judgment also comes from both from the children. Some caretakers fear judgment from the children, but also the community.
Yes.
Yeah.
Questions, Buzina? Any other questions? Okay. So what are the barriers of disclosure to children? No, you're dealing with all questions.
I'm going to do all questions.
All the three, then some. Yes. Okay. So what are the barriers? Disclosure to children. So we start with children. When we say children, what do we mean? Okay. 0 to 9 years. So first of all, when are you guys starting disclosure? When do you start disclosure? 10 years.
For me, I do support, I do start at 7 years. As early as 7, you start initiating, because it is a process.
That is partial disclosure.
But it's
Then
generally
complete starts at 10 years.
Yes, and that is why I asked. Disclosure, yes, there is partial, there is the full disclosure. So at what point do you start? That was the question. Seven. Even earlier. For some people even earlier, as long as you assess the maturity of the child, it's about maturity. Some 5-year-olds can be 5, 6, you can tell them. Okay, so what are the disclosure? What are the challenges to disclosure? 0 to 9 years.
One of them is the stigma of the caretakers, the mother.
Why? Explain further. How does that stigma affect disclosure? Elaborate. Expound on it.
Okay, the parents, more especially, may think that this young baby may spread the disclosure to the community. And everybody gets to know that the baby is being abused.
And then they become stigmatized. Fear that the whole community will know. Okay. Anything else?
There's also fear for blame.
Fear of blame.
Fear of blame when the child, the mother would think that how will the child interpret it, how will the child, if the child asks me, how did it come, what will I tell that child? So it makes the mother and the father fail to tell the child what is going on, the infection they have.
Okay. Right?
It is fear of blame.
I think now we are, remember we are talking to children, not adolescents. So,
Aren't they talking about blame?
Because you have to tell someone about so that wafuna umuntu ngayina mindset ngakhe a mindset eli negative most of the times no person go again of disclosing that will always be negative age appropriate information everyone is on so you can see what the information is on and I've not put a definition around it.
Did you know this?
if they are never to identify that the child is mature enough to disclose to personal grab.
But when you have kids find them,
try to call the mother to disclose, to tell the daughter the truth about it. So the caregiver will say no.
Yeah, difficult caregivers make it hard to disclose to children.
The mother completely refused to remember that Sunday.
So find out how to
But they also refuse because they
We
fear.
gave them time. We gave them time. Then we did it again, like, I think after like a year or two.
Those three are enough. They said three for each. We'll go to the next one.
Difficulty.
But you had talked about awareness.
The thing, if people don't know the importance of disclosure, the benefits of disclosure, then it becomes difficult.
Yes, lack of awareness and benefits of disclosure.
And as a peer educator, what challenge have you faced in disclosing to children 0 to 9 years?
Challenges. One, follow-ups, doing follow-ups after disclosing becomes a challenge. Find some of these children they don't want to come back. Or maybe the caregiver doesn't want the child to come back to the facility. So you do not know how, after
Let's say you
disclosing,
start with like
yes, to see, okay, I've talked to you now, you're back for appointment. How do you feel after the session you had last time? Then another time. Time after talking to these children. Find one is too emotional, overcrying and all that. So you spend more time on one person and yet you have others. Yes, because you don't want to hear stories that maybe she committed suicide or she ran out from home or he ran out from home.
But which is good, because at the end of the day, we are looking at patient-centered care. So if you talk to somebody and they're very emotional, definitely, because it's patient-centered, we want to have all the time, depending on how you assess the situation, which I think is good if you guys are giving somebody time. Yeah, I think it's okay. Well, maybe, but patient-centered care is the way to go. So the issue of time is that maybe you have so many. So in one session you may have like how many people to disclose to?
Can have like 5. And most, by the time you have 5, you find this the caregiver come and tell you, you know what the doctor told me, my child's viral load is high, and the doctor has told me maybe we should let this child know why he or she's taking medicine. So you find the doctor, of course, the doctor has a lot of clients, so sends that parent and a caregiver to you. So you find like maybe like 5 maximum, depending on the day. Especially if it's a children's facility, you find like 5.
And maybe for a client who needs a lot of time, it can take like how long?
Over an hour, 2.
Even 2 hours.
Now that's what I'm telling
So
you.
let's say 2 hours.
Then
Maybe
that's
all
what
day,
I'm telling
2
you.
hours.
Five
5
clients.
clients.
All day,
Now,
but each
now
2
if you
hours.
find it, the tricky part is like this. The tricky part is this. You find one of that client, the child is very emotional. Now you start talking to the child doesn't want to listen, he or she is crying. And then remember, these other parents or caregivers who are outside are waiting, and they also have other routines within the clinic to do. So Katiawo, you find you now you need to take it down maybe and then reschedule to, yes. Because you find 2 different appointments. The parent has her own or his appointment, then the child, now you're still with the child, then the mom does it to walk around.
The process
As
is
far as
continuous.
to allow like 3 of us,
you brought in that issue of trust, but I also wanted to understand,
And also the
do all
training.
peer educators have the skill in disclosure to that age group, 0 to 9?
I don't think so.
Not
Personally,
So it's a challenge.
because there's a difference between having the skill and also the passion. Those are two things that you find very few people have. Find someone having the skill and the passion. I think someone having the skill and the passion.
It's all about mental health. Depression, that could be depression, but yeah. Depression is a big word. Yeah, it can also be like a fear of developing mental well. You started the knowledge gap. Knowledge gap of health workers enable to empower these caretakers with skills of disclosure. Because ideally health workers are supposed to prepare also caretakers to have that reverence of disclosure.
Ezekiel.
That is what they call partial disclosure. No, partial disclosure starts at 9 years.
At 9 years.
Starts at 9 years.
that's fully about 15 years and
Until the process of disclosure can take like 5 years.
for sure, then whether for complete, yes, and by 15 years.
15 to 16.
Initial.
Initially is the second one. For sure, initial then the complete one.
So the level of understanding of an adolescent feel the outcome.
Oh, so it's a more like a relationship thing.
But also, maybe work things that
You might not even have been born with the HIV, isn't it?
even a caregiver like a mother can look at you and say, Ruta is ready to be disclosed to. but you are not yet ready because of the issues.
Number 3, you say number
Because
3.
of the issues around it.
So that's number 3.
That is number
So
three.
number 3 cuts across whether they got it through birth or through
Yes.
intercourse.
It is this adolescent
Okay.
disclosing, yeah,
So this is an adolescent disclosing to maybe a boyfriend, girlfriend, or family.
or family member,
So
exactly.
relationship, improve
Oh, they are at school.
at school, friend, whatever.
Okay, that one is the easiest.
But born and through intercourse. Then the other one, specifically only born with. Okay, so thank you for your time. So you have added 10 to 19. You have put it there. Okay. So
Why wouldn't you disclose? Or why would you have fear to disclose to that adolescent who has born with HIV? When they have psychosocial, or mental issues, for a health worker you would fear to disclose if that child has mental issues, and there are some processes you want to take before you disclose.
So how can you phrase it? Point to it.
Adolescent, alaze, which might be alaze signs of and mental instability. Yeah?
Or why?
When the adolescent
Is mentally unstable.
Mentally, why? Connecting. Then give us one. Yeah.
This before also, you should be rating when she starts rating this one. You'll be rating the human rating. So, okay. So an adolescent there is fear.
One of them is disrespect to the arrangements.
Discrimination.
Sana hiyo ndio kubadilika I know that we are almost of the same age. We think that the body is the passions to do things. So we are
Okay. So one you can search up. Who's rating now? No, he has a point. First say.
disrespect to the arrangements. By the parents. Thinking that he or she has less information. That is is one simple. Which one is one simple? Disrespectful is if you like the peers. No, it's not Stadium is also another point. Stadium. Fear of losing their girlfriends and husbands. Barrier to discrimination.
Maybe next.
Very good.
The last one is very easy.
Number 3.
Number 3 is very easy. By barriers to disclosure by adolescents.
Fear for stigma, fear for breakup of relationships, fear for reject, fear. Rejected by society, by community. Fear to be discriminated by community, at school, Oh no. That's what I did. Fear to be rejected. Fear to be rejected by community.
No, the community cannot reject you. The community can only discriminate you.
So to be rejected by
Maybe by loved ones.
Okay, yeah.
Loved ones.
If they are rejected,
Loved ones. Family member, boyfriend, friend, uncle, friends.
fear to be rejected by
Then the other discriminating thing can come as a second point. But to be discriminated by community, by society. Fear to be discriminated by society.
What's the difference between discrimination and
Rejection, for example, you see, just for example, like if you're staying somewhere and the community rejects you, that means you have to move, right? The community will come to your door, the chairman, and say, can you please leave our village? That's rejecting. Then discrimination can be like, for me now, for example, at my village, when we were still young, we were discriminated. tebasobola kugoba naye bakudisclose. For example, edda Fanta, then webakuga 700 shillings. So I went to buy Fanta from at the shop. Guy nangamba tetulina soda. Naye nga fridge wekiraba, eri translucent. Just soda. Nemunayanaga siguza balina siri soda. So that's discrimination. Yeah?
Self-stigma.
Stigma another mirungi mingi. Waliwo ne self-stigma.
Atateekawo stigma.
Discrimination olinayo. Discrimination olinayo.
Yateekako stigma. Then no brackets. Self-stigma. Kubanga bino bwe biggwa tuba tumaze.
356.
Ebijja kulwawo biri bisatu. Emwerabira bw'ayogera ekintu ekusooka kwogera nnyo because I'm capturing. I'm taking your photo, the name, where you're from, what. When you say social outcast, is that stigma or it's discrimination?
Should have Googled that before.
Wouldn't you fear to disclose because when you go on community?
Yes.
Baba bakola n'ebintu pate zaabwe tebakuyita ebibuwedde. So you can just put here on top here that we are what? Peer supporters.
Let's see we deco over.
Omuntu oli avakado oba tewabona oba obonabona avakado
Okusibirira avakado? Wali olidde akawunga ka UN?
Oba olidde
akawunga ka UN?
oba olidde furuutu oba olidde
Avakado? Just do this. Ngulira avakado kubuulya sapa. Tulabe oba tokyalira Obama. Bra. Wali akawunga ka UN? Kayeru. Ate UN emala okuleetera akawunga ne bagala ne photography bakupe ebifaananyi.
So Mary is prepared. You will tap you when you in our row, dear supporters.
Ruta ajja kwogera luzungu olumeruka tutawulira.
Ebiki?
Ajja kwogera luzungu ali olumerika tutawulira.
I don't know where is it. They can take the satellite.
So the board member.
Kangarete munde kama. Kangarete munde kama.
Member wachi? Board member. Board member joga. Member wachi nini? Koma mchibegari.
Baba na shoulder. Shoulder. Ribs. Actually, some ribs.
This is bad.
Body. Pelvics.
Shall we do that?
Adinze sobola muyimirirapo.
Where is that?
Kubanga njamusa.
Soko kandeko?
Yes. Joan, where is it?
I what? No, yes. Yes,
Hey. Eraser. There.
Picture
There.
through WhatsApp.
Bero.
The quality.
Joan.
Mawe.
Etu inijambo jero kamera. Nzije.
Yeah.
Nagadeka sagara ufananyi.
Stand there and then you move out. First, kuteleza everything.
Sigara wale.
Joan. You're spoiling. Meanwhile, whatever is here is the other side. So
Vivian, stop. Who brought the camera?
look here.
Bakubire wali. Ekifaananyi kivayo awo kikwata ntebe zino.
Exactly. That's a nice position.
Here.
Yeah. Butter.
Munyumye banamu. Musanamu ekirabo.
Ekyokunyumba.
Kale mubuukeemu. Jump if you know.
So if
Jump.
You tell us. 1, 2, 3.
first calculating
Kyogamba temusobola byambanga for seconds.
What's it on?
Hey.
Come on. Push that camera table with jacket or whatever.
1, 2, 3.
Atateeringa walagawa.
Ngadde nzijeyo. Wedda be baliyo.
Munyumye basatu
Okay, jump.
munyumye.
Jump. Another pose jump. I'm telling you, my goodness, seriously. Hey.
can pin there. Yeah, we just make sure we don't put them there way. And then you can pin all of them there. On this you need to run.
You know, different.
Members, we are giving each of you three for every question. So you may have 9. But in the fourth and fifth question, you have 3 votes. This one stands down. So at the end of the day, we will be able to get the nurses, you are normally which color?
We are always white.
Green. So, each person from your group has 3 peer supporters, you are normally pink. Normally pink.
You can see.
So 9. Counselors, you are normally orange. So one each person. The purpose is if you have 3 votes and you have more than maybe 5 issues, each of you will be able to rank the first.
I'm going to go to the night. Engineer, well.
Table of contents.
Grace. Sorry. How are you, Papa?
This for
I've said they give me 3. To my dad. What in the session?
Now,
What you going to want to point and stand it out there?
after you've run, just have that small, we call it what?
Stick
Small
notes.
discussion and agree that
Health workers, we got
our group is
Move health workers. Move.
and then you pick that person that is going to represent you in the start. After you run, just agree on them that these are our issues and that is what we talk about here.
No. You have to recover.
it will be the start of the
Way. What
But, okay.
you know,
kyomwagala kuleeta bintu.
Ebintu bya mubiri.
Something that shows Kampala says, right?
These are ours. You come and put your stuff the other side. Side. That is the other one.
Then you will look for the representative among yourselves. Ofunye? Are you Pia? Or administrator?
Who is giving out pay?
Pia, eh? You have 3 outstanding points now the Madden and Zoom group here. Which Ofunye? Pia, eh?
Where are our things? You choose 3 here, 3 there.
Waina madara watu wanile. Ezokubanga. Madara yatambudde na
Ani? Ako ku brain.
Buli omu ayita madala.
Ofunye nkwadde. Ani atafunye sagala mwenna mwekwase mujja noonya point.
Era abadde tebaluta. Tulina obwaffe bwe twaseri.
Alimba.
Isaac, you're discussing Pia.
No. I would just say.
And I just want to points.
You know, you know.
Bakitangambye ekyo era nampuuza. Kasoka tujjemu n'enkoota ebugumu.
Obadde otidde okudiscuss.
Sina kijja. Nawe omanyi.
Ye nga mwenna mbadde mu pinku. Apiki namulimu.
Like, couldn't you like do something?
The person will start as well.
Abo basawo.
Engineer.
Abo basawo. Abo basawo. Lala.
Engineer. Mutula tutandike.
Tebyabano batebataddeko simalipiyo bakigano bagwawo.
Bano badokita baherefu wakatola wali mukono.
Bebakozye box.
If where you sit we start.
So we understand the small discussion. You've run, you're looking at those 3 that are standing out on everything.
Who are these guys?
So agree that yes, these are our issues, that Isaac is the one going to present them, and when you come to present, don't speak for your facility alone, but for the entire group. We have 10 minutes to do that. 10 minutes, then we shall
Amazing as a group game, I know, but
yes. Points. Straight to the point.
Remember, those stick notes, just place on the points it's like you're voting. You have 3 for one question.
But we don't write.
Don't try. Just say. I say you use them to write. For instance, point number 1, I have all of you voting against it. That point has nuts. So I want to count and be able to see which are the 3 that's. Are we writing?
Doctor, you're written.
Plasma. Maiba vera mu bleeding.
Even if you press it there, they will know it's real.
As long as
I hope it's true when you come, you are able to tell us that in our group, these issues still down.
I did photography and videography. I used to work with Watoto back then. Before I entered the whole facility thing.
Let's try to put on the side the cover. Let's not cover the content.
Don't cover the content. Organize yourself.
Kale be engineer yalithathe.
They can stick on each other.
Engineer yepaste.
Like what we need.
Let them stick on each other, but don't.
Yagambe points zamu.
Kugambe Dr. Jiat koze. Kata wala bono papa wote bakuwanise. Ngoli mukono onasike nosi just. Kama mind baziguza upset.
Abamuwandiise zo bakole batya.
Olya muwandike.
Oyo
ndatugamba mu question wandika 3 outstanding points.
naye Ezekiel watu yabadanga.
Ezekiel bwe yagala.
Watu yabadanga. Yekyusiza
Mwambaza amatu g'embuzi.
Ezekiel kati alika n'ebba.
Was on camera, you guys. Can you bring the camera?
But they don't even
You want evidence? What you wagambe kati nowewe. Olinda. Ama maze mwenye londa. Weka wana. Nza nabagambye ngini yabya. Saga. Yagala kunkuba ifaananyi. Kumata. Kagala nteeka yo. Ndakachukula ndasiza kugenda. Amaze kuba kigano kubanga kibadde
Praise. Where?
What shows? Wow, we still have to. Which is?
Some things are only for money.
abapinga babula bamwanda
Hey. Hey. It's okay. That's what you.
Yes, the quality, but the
Musumba.
By osmosis. Not my words.
Buganda bagayi bajjayo lula.
Simplify one. Put in the table. Engineer n'abagamba. Bueno, angekyame. What's his name?
Obani yalimbye ba counselors mu ignorance.
To make matters worse. To make matters worse. Mubaddemu engineer ne Gaina. Gaina n'agamba neddasewo.
By osmosis.
Waffe tetukosa lula.
N'amugamba angekyame.
questions?
Not yet.
Oh, they want to record.
And one of the questions was...
Not yet. We shall welcome the discussion officially. And then you start.
As they set up themselves, I want to find out from the facilities, how many of you brought back client satisfaction surveys? I only have for Butunduzi and Nyamavuga. But from Chembogo, yes, Pongo. These things were given to the peer educators to do client satisfaction. So they got them many months ago, in fact 6 months ago almost. So Muzinga, client satisfaction surveys. Bamboo, you gave them to, remember, after the meeting,
day 2, and we are here for our workshop again on disclosure, and we are going into a good moment of the fishbowl feedback. And in this session, you're going to be sharing feedback with the entire group, feedback from your group with the entire participants. So we just want to hear insights, what you agreed, what you talked about, what are those barriers to disclosure. But as you conclude, we may also a bit focus into overcoming those barriers, again in the 3 questions like we discussed. So, ladies and gentlemen, before us are the doctors and nurses, and then we have the counselors, and then the peer supporters, represented by one person from each of those constituencies. So I want to give you the opportunity, when you get the microphone, you'll tell us your name, you'll tell us where you work, what you do wherever you work, and the constituency you're representing, and then you go ahead and submit. Again, like we said yesterday, if members from your group feel there is something that has not been mentioned and they want to make an addition to the discussion, they'll simply walk to the panel and they'll tap on the shoulder of the person representing them, and then they'll be able to take the seat and make an addition to the discussion. When all the panelists are done, if the audience feels there is something to contribute, still you'll walk in front and make your submission. And once we are done with that, then we shall have come to the close of our workshop today. So thank you again. Thank you. We are excited to see you, ladies and gentlemen, our distinguished panelists. And without wasting any time, allow me pass the microphone to somebody representing the constituency of the nurses and the doctors. Welcome to the floor.
Thank you. Thank you, Mr. Ezekiel. I'm Sally Vincent, a registered nurse from Kiamboko, Holy Cross Health Center 3, Kianjojo District. I work as the art in charge. I'm here to represent nurses and doctors. We looked at 3 questions. One of them was barriers to disclosure to children 0 to 9 years. The second question was barriers to disclosure to adolescents, that is 10 to 19 years. And the third one was barriers to disclosure by adolescents. On question 1, we looked at a number of issues and we came up with these 3 outstanding barriers. One of them is knowledge gap to empower caretakers to disclose. So that is on the side of health workers. Some health workers have less knowledge about disclosure. Others fear to disclose because they feel they have less information to give children and their caretakers as far as HIV infection is concerned. Another outstanding point was social stigma or fear by parents, in that these parents think that in case they disclose the HIV status to their children, in one way or the other, these children might go while playing with their fellows or with other people. they may end up leaking the information, hence causing disclosure difficulty. Then the third outstanding point was fear to lose the parental bond or parental love. So these children, after being disclosed to, we think that they develop questions that how did you infect me? Why? Were you taught on the prevention methods? So in that process, these parents, they fear disclosing the cell status to their children. I think that's what we had to look at on question 1. Then on question 2, it states that barriers to disclose to adolescents. So we also came up with 3 outstanding points. One of them was social stigma. These adolescents fear to have on social stigma, the adolescents, sometimes it becomes difficult to have them or to disclose them too, because they don't pay attention, fearing to have the information spread to the community. And you know what happens when the community knows that the adolescent is infected with HIV. So in this case, when reaching that time of disclosure, it becomes very, very difficult, both on the side of health workers and the adolescent, him or herself. Then another point was fear of the peer or the adolescent losing their partners. So this was also one of the outstanding points, that the adolescent may fail, may deny disclosing, believing that after disclosing, the partners or the sexual lovers or the lovers may run away after knowing their cell status. Then the third outstanding point was lack of enough counseling and guidance. So they lack the knowledge, they lack the information that their disclosure is of paramount importance. So they can't disclose when they are not given, they are not told that there are benefits involved in disclosing to their partners or to other relatives or caretakers or any person in close relationship. So that is what we had to cover on question 2.
You said in question 2 that they fear to lose their loved one, their boyfriends, their girlfriends, to disclose. Is that by adolescents or to who?
To adolescents.
How about the health provider disclosing too?
Because on number 2, we want to hear what hinders you to disclose to them. If you don't have a boyfriend, what stops you to
So it is to
disclose
adolescents.
to them? Okay, go on. I hope you've got my point, members.
Yes.
Go on. If somebody has something to add from this side, you know what to do. Okay.
Okay, we are going to number 3. So number 3 was assessing for barriers to disclosure by an adolescent. So among the many points that we looked at, we came up with 3 outstanding points. One of them is disrespect by the fellow age mates. So this adolescent would be able to, I think the question is saying disclosure by...
Yes, they are disrespectful, and so you are not able to approach them and maybe disclose to them.
Exactly.
Which is okay. Continue.
Yes.
Or you might have provided attitude affecting disclosure.
Meaning the issues the adolescents have that make it hard to disclose to them. And you're right, continue.
Yeah, on this point we specifically mean that when an adolescent is in the community trying to approach those fellow adolescents, sometimes they look at him or her as having knowledge deficit and is unable to give them the complete package or the valid package that would be given. Then we also looked at the lack of privacy and confidentiality. There is a perception that these adolescents are unable to keep secrets in the community, so it becomes difficult for them to be disclosed to by their fellows, thinking that this adolescent may not keep their secrets. Then another one is the fear of stigma, of discrimination. Actually, it is discrimination. So it is also a point that we looked at, as we think this adolescent, when you're going to tell these fellows to disclose himself or herself, they will ask him, are you also infected by us? Are you affected like the way we are? Are you infected with HIV? So this adolescent, him or herself, may also fear because of the discrimination that will come up in the community. I think that's all we had to come up with. Thank you.
Does a member want to make an addition? Members from the group of the doctors and the nurses? And yes, you said the other side of overcoming the barriers. So yes, which solutions are you thinking about?
Actually, we had not discussed about that one, but we can still brainstorm. I think one of them is peer-to-peer attachment. We know sometimes it becomes easier for people of the same category, of the same age. When they come together, they share their ideas, they share their challenges, and in that process, they easily disclose to each other the self-status, basing on the challenges they face and other issues that they share. Another way of another remedy for having the disclosure done is emphasizing or strengthening the counseling skills of health workers, such that good information and convincing language or conducive language is used in the disclosure process. Another issue or another point is that there is need for early starting the disclosure at an early age, because it is a process, it is not an abrupt thing to do at once. So we need to start at around 4 or 5 years. We give partial disclosure, then at 10 years we give the full or the complete package about disclosure.
Maybe just for the interest of this group, what is that form of partial disclosure like at 4 years? Because I see people looking and wondering, again, disclosure at 4 years, could you just...
I'm saying partial disclosure.
Yes, they want like what? The partial. Can you guys walk and add to the discussion? Come on, say you're making that video.
Yes, anyone. Guys, let's go. Yeah, let's participate.
Save life. Engineer, where is he?
Engineer.
If you know you have to leave for
Clear information. Come and support you mean. You tap him, he stands up, he leaves you see.
Okay, somebody is making an addition to that point regarding disclosure. At what age does it really start?
My name is Joseph from Nyamabuga. The best age to do partial disclosure is 9 years. We start at 9 years, then we keep moving 10 years, then we do full at 15 to 16 years then.
Yes. Again, to re-echo my question before I welcome Dr. Margaret, what is this kind of partial disclosure? What are you telling them with partial disclosure at 9 that you're not going to tell them? I mean, that you can't tell them until they are 13.
This is like you're trying to bring in the little knowledge about how, bring in the little knowledge how the child got this, and you try to bring in little knowledge, but you do not fully tell this child that this is the disease and this is how it came, but you tell them you have to take this drug for this reason so that you do not get these infections and this. Then as the child keeps moving to the next age, we tell them, that is at around 15 years, that's when we can be open and we tell them we are taking this medicine because of this and this.
Okay, let me jump in. When the disclosure is done based on the maturity of the child to understand what is being explained. Let me give you a story. There was a community health worker who adopted a child. The child was adopted at 2 years. The mother had died. And then she took the child to the health facility, was started on ARVs. The child has been taking ARVs, has grown up to about 5 years. And this child is like, I'm not going to take this medicine. Why every day? At that time it was still the penalty. So she would tell the child, if you take it, if you take this sweet, I'll give you biscuits. So the child would even go out singing, Auntie, where's my sweet so that you can give me biscuits? Where's my sweet so that you can give me biscuits? And the people in the community were concerned. They were like, for you, every day they give you sweets and then you get yourself biscuits. The other kids were asking. So she got this child and then sat down with the child and said, there is some information that you can talk out, and then there's some information that we can't talk in the house here. So for example, the things about this sweet, don't talk them outside, okay? But if you want to talk about how your nursery school was, and well, that one you can't tell others. So meaning that, already they're talking about the ARVs that the child is taking from as early as 5 or even 4 years. So the child now knows that, anything, talk about my medicine, I cannot tell them out. I cannot share them out. But other things I can talk about. So it's based on the gauging of maturity of a child. Some children grow fast, others take time. Okay? So as a caretaker, as a health provider, you gauge and you start a conversation. So the conversation, you can use gestures that a kid easily understands, relates to, but you are slowly building up. Now, at a later stage, you start now telling the child and say, remember when I told you about those sweets that you don't tell people outside? Well, this is medicine that you need to take because you have some illness that is different from others. So you start opening the space slowly as the child grows. Okay, so In our guidelines, they say disclosure should start as early as 7, but again, there's a clause there that is dependent on the maturity of the child. Okay. And then full disclosure happens later from 12 years. Full. But partial, pola.
Well, thank you so much, Dr. Margaret. I think it's clear on what partial then eventually full disclosure is. We are going to move on, ladies and gentlemen, to the next group, and that is the group of the counselors. But I think I want to make it more interactive, and this time we are going to handle question by question. When the counselors share about disclosure to children, we shall pass over the microphone to the peer supporter, and we get to hear their side of disclosure to children, and then we get back and we keep it that interactive. Right? Okay, over to you from the counselor's constituency. You tell us your name, where you're working, and the constituency you're representing. Thank you.
Good evening, everyone. Good evening. My name is Maria Praise Nasamba. I am representing the councillors today. So question one, sorry. Barriers to disclosure to children, that is 0 to 9 years. For us, we looked at it in this aspect. When you look at the barriers, you can break them down in 3 aspects. You can break them down looking at the knowledge that you could be having. Then you look at the attitude and the practices. So when you go back to the knowledge, what are the barriers that are going to hinder the kind of knowledge you're going to pursue? The knowledge, you have the fear of how this caregiver will perceive this information. Remember, when you're giving out information to the child, remember they are 0 to 9 years. We must have a caregiver around. So initially, we are talking to the caregiver, nurture sense. So that fear that you could be having of how this caregiver is going to perceive that kind of information. Then you look at the inadequate information that the counselors could be having about HIV and AIDS. Not all information is well equipped with by the counselors. Some information, they are limited to some information. So that is going to lead to information gaps between the person you're giving the information and you giving the information. So the child is going to have those questions that are very many. Even if they pose the questions, it's going to be hard for you to do what? To answer the questions. Then we have you look at the lack of appropriate information to pass over to this child. You know, HIV is very wide and it is broad. I am not going to, I may be giving out the information to the child and end up talking about condom use, which is actually very unnecessary at the moment. But yet I have to pass on the information. So you look at that inappropriate information that you're going to give the child. Then you also, since we are talking about the child, the limited information tools. Because these are young children. They understand more with pictures, drawings. So you may find a facility that does not have those ECDs tools. The child will really, you're talking about this, I don't know what it looks like. So I'm left in a gap there. I don't know what you are talking about. So when you look at the attitude, the barrier, the attitude of the child, I've broken down this information I've disclosed to you. They're going to emotionally break down. We expect that. Then also, you look at the stigma and discrimination from the peers. Yes, I've told you what is going to happen next. Then also you find some families that there are families that we call the child-headed families. So after disclosing this kind of information, what is going to be the way out for you? Thank you. That was our one.
Okay, great. Let's move on to the peer supporter to also share with us those barriers of disclosure to children. But as you share that, remember you'll also share with us what you think are solutions to these barriers, like we agreed. So we'll need to know what can be done, especially practically from your experiences, how it has been and what you think can really be done. Yes, over to you, the peer supporter.
A good evening, ladies and gentlemen. By names of Ruta Edwin Moses, and I'm a peer supporter. I'm working with Baylor Uganda Children's Foundation. So we had our first question, barriers to disclosure to children, as all of my colleagues have said, 0 to 9. And the first one that we noted down, or the first barrier that we noted down, was some caretakers fear judgment from their own children. I'll circle around that later. Then the other would be protecting the child from stigma, lack of awareness on benefits of disclosure. Then lack of skills in disclosure to children. So if I'm to take you back on the first one, is some caretakers are afraid of getting judged. If you're a parent, you know this. For example, we sit down with your child plus you present in the room, and then we start off with small talks as we're building our way to the full disclosure. Now, here comes that after telling this child what he or she is, definitely the child will start thinking of so many things like death, why me, where did you get it from? And let me tell you, these children are actually smart, they're actually intelligent, they go to schools, some of these children are actually exposed. So they'll think maybe the parent cheated somewhere and got it and, you know, had it all along. And then, if I'm to move to lack of skills on disclosure, you'll find that maybe as a person you make a mistake during disclosure, or maybe maybe one of the person who is doing the disclosure may dive into the topic, and then that would cause other issues. That includes emotional damage and other things. Then the other, protecting the child from stigma. You may disclose to this child, he or she will understand, and then will also feel like telling maybe a friend, or maybe informing someone within the community. And then that's where the stigma starts from. So you find the caretaker will actually reject you or the health provider from disclosing to this child. And then lack of awareness on benefits of disclosure. I had, from my own personal experience, we had a child who was gaining a lot of viral loads every time they would come for a visit. So we talked to the parent and we're like, do you know that your child's viral load is actually not decreasing, it's actually just increasing each time you come back here for your appointment. The best thing would be if you would inform or if we would disclose to your child, we will let him know his status. So we sat down with this child, a counselor was present, I was around, the mother and the child. So I asked the child, do you know why you're taking your medicine? And the boy was like, yeah, I have a heart condition. And I asked him, do you take it every day? I was like, sometimes when my mom gives it to me, I keep it in the mouth and then I throw it away after. So we found the reason as to why actually the viral load was going high. So we started off with baby steps as we're building our way up to the full disclosure. And then once we reached the point of disclosure, we're like, now do you know what HIV is? And then it's like, yes. Even at school we study about HIV, and I'm like, okay then. So you need to take your medicine. So these are the benefits. When you take your medicine, you actually, I gave him a form of, because he likes watching action movies. I was like, yeah, you see when you look at the police or the army, so when you take your medicine, you actually giving your soldiers in your body system strength to fight off this enemy. So every time you take it, just know I told him you're giving them a backup. So from there, we started off with the following ups, and it was successful. And it worked out, and the mother was happy that now the son knows what he is. Yeah, so those were our three major barriers that we looked at.
All right, thank you. So for the solutions, contribute solutions to the two presenters. Guys, please, solutions. Solutions, move on to the discussion.
No, we have discussed.
Okay, all right, so solutions. Yes. What are the solutions to the challenges that we've raised? How can we address them? How can we address the solutions?
Solutions.
So there are three groups there. One is for the health providers, the second one is for the counselors, the other one was for the peer educators.
So I'll speak for the counselors on the point of ignorance, and our solution was leveraging on the social media for the young people, because that's where everyone is, and also to be inclusive for the hard-to-reach communities. We spoke about radio talk shows. Then we spoke about the posters, animation sort of, like this behind me. That's why I put it here. Yeah, so that it could easily speak for those that could not either read. So that's how we're looking at the ignorance bit of it. Then our
So this ignorance that you're talking about is by is it the ignorance of the counselor in counseling, or the ignorance of the adolescent in disclosure of the adolescent?
Adolescent.
Okay, so this part was about disclosing by disclosure to an adolescent, and then there was a part they talked about disclosure by an adolescent. So when you talk about social media, maybe expound. Like what sort of messages will be on social media? Because you cannot disclose on social media.
Yes, you can disclose on social media, but we are empowering the young people through advocacy-related messages, so that they cannot disclose, but they are open to stand up and either speak for themselves. These are the challenges we have, this is what we are facing, these are the solutions that can work for us, and not old people speaking for us.
All right, thank you. Yeah, so the materials do speak, so maybe you could start a conversation through using maybe even storytelling, the pictures like she said. Let's hear more.
On the knowledge gap of health workers, the disclosure process, I think we can equip health workers with knowledge and through mentorships and coaching, and during our daily routine CMEs, so that we can be equipped with enough knowledge so that we can be able to disclose to children and young adolescents. Thank you.
Okay.
I'm adding on the peer supporter, and he talked of inadequate skills, and another way that can be addressed is by having us trained to be able to handle disclosure to children. And then we talked of lack of awareness. So how can we make sure that we understand the benefits of disclosure? That is sensitization. We have to put out these messages at the health centers, at the facilities, for people to know. Okay, even the caregivers, when they come, they see these messages. For example, at Alive Medical Services, we always have the screens at the point of the entry point, at the adolescent clinic, at the counseling, and they talk about all these stages. When you know your HIV status, disclosure, all those steps are there. So that is how I can see us addressing those challenges or the barriers. And then having training us to understand these skills may not necessarily mean that we need to be at a certain place, but it can be through daily interactions with experienced, or let me say experts, who are already trained.
Okay. All right, so what I'm hearing, and what all of you have probably dwelt on, is the issue of lack of information of the care of either the counselor or the peer educator or the health provider. Fine, that's like top notch. So what are the other solutions to the other challenges that were mentioned? Because it's, yeah, everybody has dwelt on knowledge gap. There are things that I had around. So for example, I think someone had mentioned about fear of hatred.
Judgment.
Fear of judgment. There were things around social stigma. So what are the solutions? What can we do? Disclosure. And why we are really dwelling on this is because at our facilities, you guys are the health providers. When someone has come out of the lab, the lab technician does not tell them, just gives them a paper and says, take it to the south. So now you the counselor, which many out here, do you just yes? Oh, let me first ask. These guys have been receiving from the lab. Let's hear. Let me come to you. Yes.
My name is Mbambu Iflesia. When a patient comes from the lab personnel, it depends to the system of the facility. The lab person may take the results directly to the counselor, and the counselor calls the patient. Or some facilities, it is the patient who takes her own results. But there is a challenge on that issue. The patient may be Mbambu, who knows how to read. And that patient is likely to get a problem on the way, or disappearing on the way. And this happens at our health facility one time. A lab personnel gave the results to the patient. And when the patient reached at the way, he opens the paper, and it was positive result. what the man did, he ran away. And on the way going, that boy saw me and he was saying, Msamambu, I'm I'm leaving your place, I'm going, but it seems I have some problem. Then I said, please stop on the way. What is it? Let us talk. And he was saying, no. The last person has given me results, but I don't want to share it with anybody. I tried to convince the man, and if the man gave me the medical form, and it was positive results. I told him, do you know, let's go. Let's go back to the facility. And we took the man to the facility, and we entered the counselor room. The counselor also never knew that the boy has run away. Then we counseled the man. And in his own thinking, that he was a married person, he never wanted the woman to be disclosed to, because there would be a tug of war at home. So what we did, said, please, me, there is no way I will tell that woman who have been quarreling. The woman has been telling me that I'm a womanizer. Now, me, I'm going to tell the results, I will not tell her. So I said, do you know, it's us who is going to help you, and the woman will not take any action. So we helped the man to come out of it. It was a long story.
Okay. So let me rephrase again my question. Among the children you have in care, I don't know, there are 20, there are many actually.
There are 156.
Yes. All the 156, have you disclosed to them? No. Why? In fact, those are things we wanted coming out, and then so that we find solution. How we
some of them have been disclosed, some of them not as yet.
Why?
The reason is, the reason are some of these reasons that we have given out.
So what is the solution?
So the solution is, for me as a person, what I'm going to do. I'm going to sit with my health workers and give them a CME, the way how we can come out with this, how we can solve these problems. And even the caretakers and the children themselves, we will be giving them health talks, such that they can be aware and they can know what to do in case of disclosing. That's the few I can talk.
Yeah, thank you. Because we want to really bring it home that at our facilities, not all your children are disclosed to. So when you say young, what do you mean? Okay. Okay, fine. But do you mean that those who are above 5 years have some sort of partial disclosure?
Yes.
All of them?
Yes.
Okay, no, for Baylor, yes, we can add. But these facilities, these ones on the ground.
70% of things are disclosed.
80%. So the other 20%, what is the challenge? What is the solution? The challenge is you've mentioned. Now when we go back, after when we go back, we don't just start. Gundi? Yes.
Okay, I'm not a health worker, so
It's okay.
but what I see that works or may work is linkage. For example, I work at Paediatric Uganda. So when these people come, we work with health facilities, cases here to be specific. So we link them there. So these people, we empower them in such spaces. So by the time someone is coming from partial to full to I didn't know to now I know, they have a safe space. They have either the information, they have, the environment is enough for them. So I think that is what would work for health facilities, especially all organizations that would like to collaborate with them. A linkage is better, because how will you break it up? But someone who is under the peer, under the counselor, we don't know, but at least we can move with them to either these spaces and then we shall move from the partial to the full, and then free from our point, stigma, both self and environmental. Thank you.
Thank you. Okay, and now this is going to the peer educators, okay? We know they are a resource. Peer educators are really a source and they've done good work. But there are also peer educators who are not confident enough to disclose, to stand up and talk to their fellow peers, okay? You'd find, I've definitely interacted with several, the YAPs. You'd find that some of them, I think because also, because it might impact their relationship with their significant other, they don't get to disclose. So as peer educators, what is, they are here. There's some of them here. A solution for peer educators. What do you think peer educators can do better as a solution to enable disclosure? And then we wrap up.
My name is Mary Grace. I think we need some more meaningful engagements whereby we need to be taught how to handle some adolescents, on how to disclose and how can we be confident to disclose to them. I think we need some orientations, even some capacity buildings.
Okay. All right. Okay. So thank you very much. As a wrap up, definitely, I think as you guys heard in the presentation, disclosure is not easy. It's a very, very thorny issue. It's not easy. In fact, this issue of fear of the caregiver, it's very, very big. Fear of blame, fear of hatred, fear that the child is going to blame me. It is very, very important. It's really painful for the caregiver, the mother, to really sit down and talk. So, like we've all heard, it's a process. Take it step by step in the disclosure. I'm hoping that tomorrow morning, in the recap, the guys who were in for the disclosure will be able to share tips of what was spoken in that session. Okay? Yeah, so over to you, Ezekiel. We're done for the day.
Some peer supporters cannot disclose. Then I ask, is disclosure a must?
Okay, so as a quality of choosing a YAPS or a peer supporter, it is clearly written that they should be comfortable to disclose to other peers, basically to be able to share their situation, to help other peers to also come out, to open up. And basically so many other peers have really been helped that way, that they're able to connect and say, okay, I'm not alone, because this guy is actually looking good, so I shouldn't fear the situation.
Yes, different mindset of disclosure.
Okay, you could
share.
share.
Disclosure would be more important if someone, because I'm looking at disclosure in a way that disclosure shouldn't be a burden or a problem to peer supporters, in a way that it's not a must that I should disclose my status to you. But if I give you the information that you are supposed to have and guide you in the right way. But me, I'm looking at disclosure to be more important in discordant relationships. Because there, you could be having no say about it. But when you are disclosing to other people, you can have a say, either to say no or yes to them, either to disclose or not. That's what I thought.
Okay, he has a response.
I want to respond to you on this. Now, as a peer supporter, you need, first of all, to become a peer supporter, you need to be trained. After being trained, you need to learn to love your medicine. At Baylor, Uganda, we test and see your viral load. You are not going to go to another peer preaching or telling them to take their medicine, yet you're failing on your own. Then third is that you need to be free or open. You need to share your story with this person so that this person gets to know that he or she is not alone in the struggle. I have done community visits. I've talked to communities and I tell them about my HIV status. Then they get to look at me, they see a tall guy, very handsome, healthy. You get my point? I have gone to schools. I have gone to schools and sat down with so many young people. So there is no way you're going to tell this, but there's a reason why the peers came into this game. A doctor is not going to sit down with a peer and tell them, you need to take your medicine, if you don't take it, you'll die. This peer needs to sit down with a fellow peer, let them know, take your medicine, going to look good, going to be healthy, you're going to achieve your dreams. So this person sees you as a figure and be like, if so-and-so could do it, then I can also do it. A doctor or a counselor doesn't have the time, actually day-to-day time. If they go back home, they're stressed, they have families to take care of, they have dates, they have so many things. So as a peer, you even reach, for me I even receive phone calls in the night. And I'm like, yo, how are you? And now I have an issue. I was supposed to take at 10, but I came back at home at 11 p.m. Can I still take it? You get it? So you need to be open, you need to give them time, you make them your friends. That's why when a peer comes to a facility, they're specifically looking for someone. We may be 25 peer supporters in the facility, but this peer looks for so and so.
Because it's open.
It's open.
They're able to connect.
This is what I was sharing with my group. You can't be trained, but you also need to have that passion. Okay, have I answered your question?
Thank you. Doctor. Okay. Yeah. So thank you very much.
Thank you very much. And I think Chikandwa has a very interesting story to share.
This is a learning forum, so we really want to hear what is happening in Chikandwa as well. Disclosure, what's going on there, what are you guys doing better that can help this meeting?
And as Chikandwa comes on board, I think we are all agreeing that disclosure is very, very important in this fight of achieving treatment adherence and the suppression and all that. And like Praise was saying, we are not saying go to Kiseka market and begin proclaiming, hey, I'm HIV positive, I'm HIV positive. But you disclose for a purpose and to people that matter. People who are going to support you, but also if you are supporting somebody who is in that situation and you want them to be better, then you really have to show them that you are like them, but you're better. And that is through disclosure. Yes, Chikandwa, what's happening?
Their clinic.
Like in most cases, we normally have the adolescent clinic. So I sometimes conduct group sessions depending on their age bracket. So we talk about some issues for them to share ideas. In case anyone brings in a topic, we of course I liaise with some of my colleagues like the art in charge. We talk to the adolescents in case of anyone with an issue, we pick that adolescent and we talk to him or her, and we share what basically disturbs the adolescent. Now, when it comes to disclosure, in case of any partner,
yes.
In case of any adolescent having a partner, we welcome the partner. But first, they have to consent, because normally, any person coming with a partner, sometimes someone has just found someone from around, or someone just saw that person maybe 2 days ago. So coming in here, I have to first let them consent, because you might do that disclosure when they are 2. After now disclosing, this some other person now says, if you're positive, I'm not continuing with you. Meaning, they will have to distribute other information that we've talked around to community. So, I'll have to first let them consent if they really know that it is a couple. Because some couples might come to you, but when they have not consented, they have not decided yet. But of course, you have to first talk to them, give information, give the importance of disclosure. After them accepting, that is when you can start up with a process.
Okay. So the other question that maybe we're asking is that, how many children do you have in care, and are they all disclosed too?
Like to me, I've so far with 10 to, the ones I've disclosed to around 3.
Okay, and how many do you have at the facility?
The ones I have at the facility, both adolescents and children, are around 49 to 50.
Okay.
49.
So of all these 49, like overall, how many have been disclosed to? They know their status, or they've had partial disclosure and the journey is continuing?
But at least for those ones from 10, just a few of them doesn't know, but the majority from 10 knows. But then the other ones, it's the caregivers who are aware. Yeah, because we've been having adherence meetings, the caregivers meetings, and we discuss issues of disclosure. But when they reach that age of 10, they normally know, the majority knows.
Thank you. So, Ezekiel, I hand over to you. Otherwise, I think the energy levels are now very low. Yeah, but it's a very exciting discussion. It's interesting. And if we are to achieve the 495, all the children, the adolescents, the young people who are living with HIV need to have some sort of disclosure. It helps with treatment.
And that marks the end of this important conversation. Ladies and gentlemen, we want to thank you very, very much for contributing positively to this discussion. I want to assure you that your contribution has been treated with the utmost importance, and we thank you that it's going to make a great deal as far as advocacy for frontline health workers is concerned. I want to believe that you also who walked into this room is going out at least with some fresh ideas that you'll continue using at your workstations. So we thank you very much for being here. And most importantly, our panelists, let's put our hands together and appreciate them. We thank you, ladies and gentlemen. We give you flowers, we give you thunder. Yes, at the count of 3, 2, and then 1, we give them the thunder. Okay, 3, 2, 1.
That's not how it's done.
3, 1.
There's some other panelists.
2.
The panelists is behind me.
And finally, thank you very much. Thank you very much.
What about Bruce?
God bless you.
Thank you so much.